Hello and welcome to the final WENTS podcast in this series called Conception to Mat Leave, Pregnancy as a Surgeon. First of all, I'm going to introduce myself and my host. So my name's Miss Paula Coyle. I am a locum paediatric ENT consultant at Imperial College Healthcare NHS Trust, the past president of WENTS, an IVF warrior and a mum of one. I'm very privileged to introduce Miss Annabel Kemp, who's an obstetric and gynaecology consultant at Exeter who specialises in IVF and recurrent miscarriage and is a mum of three. And my co-host today is Miss Victoria Sinclair, who I'll let introduce herself.
Good morning. I'm Victoria Sinclair and I am a mum of three as well. I currently work as a specialty doctor at the John Radcliffe Hospital and have been the SAS rep for the WENTS committee until last month. And I've had some experience of pregnancy and working, and also of working part-time and full-time throughout all of that. So hopefully we'll have some interesting things to say today.
Just to set the scene for today, there are some papers, which I'm sure you're all aware of, that talk about pregnancy and shift workers in general, and also being a surgeon in general. And this is some of the things that made us think about where we could go with this podcast. So Coyle et al. In December 2019 said that pregnant women who work rotating shifts, fixed night shifts or longer hours have an increased risk of adverse pregnancy outcomes. And Davari in 2018 did a historical cohort study, and that showed that rapidly cycling schedules of shift work may cause an increase in the incidence of preterm delivery in pregnant mothers. More recently, in surgery itself, Pownall et al. In December 22 said that plastic surgeons are at a high risk of infertility, miscarriage, congenital malformations, and obstetric complications. And Cesarin et al. In 2019, and I apologise if that is said horrifically wrong, showed that radiation and infectious agents, that surgeons are more likely to be harmed by those than other physicians, and that they're also at risk of strenuous physical labour affecting their pregnancy. And the unpredictability of this occupation, prolonged hours and stress associated with work can affect future mothers and her child. So originally we sent a questionnaire out on social media for all surgeons, not just ENT surgeons, to tell us their experiences, good and bad, of pregnancy, IVF, infertility, and managing that. So we're going to start at the very beginning, how we can plan our pregnancies. Over to you, Victoria.
So the first thing to say is that on listening to what people have said and responded, there's no perfect time for planning this when you're in a surgical career. If you have got a number and therefore you're in a long-term rotation, or if you're in a permanent position, such as a specialty doctor or a consultant post, it can be easier, but it's never a perfect time. So I think the key to say is when you do become pregnant or are trying to become pregnant, you just have to crack on. But what you want is some support, and you want that right from the very beginning. So I think the first thing to say is find your friends, your colleagues, the people that you trust to help you with that. If we talk about first, when you do become pregnant, what do you have to do? So you don't have to say anything at the beginning. You don't have to tell your employer for quite a long time, but you do have to tell them that you're pregnant 15 weeks before you are due, because that's when you have to tell them that you want to start your maternity leave. But ideally, you tell them as fairly soon so that you can plan things and they can plan things. So you need to get them to sign off your MAP B1 form, which is something your midwife will give you once your pregnancy has been confirmed. And that is how you can kickstart your maternity pay and organising for all of that. You have got some legal rights as a pregnant woman, and it's important to know that. So you have paid time off for antenatal care, and that includes classes. And so you are allowed to go to an ultrasound at a time when you'd normally be working. Obviously, we all try and arrange things so that we don't impact on our clinical day, but you can't always do that, and that's okay. And particularly if you're doing IVF that requires multiple appointments, you need that time and you're allowed that time to go.
I think you're allowed once you're pregnant.
Once you're pregnant. So before you're pregnant, you're not allowed.
Not for IVF, no.
So unfortunately, that's part of the struggles of IVF. In some hospitals, IVF is considered cosmetic, so therefore you're not allowed any time off, and some trusts won't have an IVF policy at all. And so you have to take it off as annual leave or sick leave.
Yeah, that's true. There's no legal requirement for your employer to give you that time off. Having said that, I would hope that most departments would look fairly favourably on someone that was undergoing that, because ultimately they want you to be fit and well and happy at work, and that's going to have a really big toll on how you are emotionally and mentally.
And have you got any other suggestions, Anna, about when not just trainees but consultants, anybody starts to plan a pregnancy, do you think?
It is really hard. From a purely medical point of view, your ideal time to conceive your first baby is probably between the age of 25 and 30, particularly if you want more than one pregnancy, because you need to allow time to conceive and to carry those pregnancies and then recover after each one. Realistically, particularly in medicine, we tend to leave it late. We're busy doing other things. We are career driven, and you're not that far into your career at that point. The issue really is if you leave it much beyond the age of 35. If you conceive quickly, that's fine. But if you don't, and it takes you a couple of years, you're then hitting into the age 37 and above, where it is harder to conceive even with IVF. There's no real way around the age of your eggs. Even IVF can't help with that. So the sooner you can, the better. Taking into account things like your exams, wanting to get through training, whether you can afford to go less than full time, how you feel about that, and obviously your relationship status, which has got to be the most important thing of all.
I think, as Victoria said right at the beginning, there is no right time, and that's what's really hard. And I think when you talk to your colleagues, I think especially, well, I don't want to generalize, but some of the older male colleagues will maybe have some opinions about that. So, and, I think I've had a lot of trainees even this week say to me, oh, it's, once you get, I'm not going to have children until I become a consultant. And actually it takes a really long time. I became a consultant at 39. That's quite old to start trying. I mean, maybe it suits you socially and, with your relationship status and your security and things like that. But I would say, actually, if you've got a number, you're actually very secure. And so they can't get rid of you because you're pregnant. There will be other trainees in the region that can be slotted into your spots, hopefully, so that the department can get cover. When you're actually a consultant, when your stuff all gets cancelled, it's your name on everything. It's your clinics, it's your theatre sessions, it's your patients that are not going to potentially be seen for a year unless they can get a locum. So in some ways, I feel the pressure is harder now if I was to do that now than when I was a trainee. I don't know how you two feel about your experiences doing SAS and different surgical speciality.
I think that's a very valid point, actually, because when I was pregnant, my second pregnancy, I had been working full-time as a LAT, so as a registrar, and I was very well supported, despite not actually having an official rotation, but you are protected because I had a contract that covered me and they gave me maternity pay and they looked after me in just the same way as any other registrar. And if I did have to come off nights towards the end, and they were very supportive with that, and it wasn't a problem at all. And I think you would feel guilty now that I have clinics. If I'm not here, they don't happen. I would feel quite a lot more sort of conflicted about saying, well, I really don't feel well, I can't do this today. It's a lot more difficult than if you can say, well, there's a registrar that could come and help and we can support each other. I think it's quite important to also have good colleagues, to talk to your colleagues, because I think a lot of people are really supportive of their colleagues. As a registrar, you have a bigger pool. You have more people around that are at your level than when you're a consultant, at least where I work.
I would agree. I've done pregnancy and maternity leave as a trainee and as a consultant, and I think they both present different challenges. I don't think there's one is a better time to do anything. There are certainly more protections as a trainee. Equally, being a consultant is nice in lots of ways. You have a lot of flexibility and team knows you really well and all of that. But I think it is really important whenever you fall pregnant to remember that I think we as women in surgery often feel guilty and shamed about not doing the work that we feel we should be doing. And actually being pregnant is a really important part of life. And I think the majority of our colleagues do support us doing that. And it's important not to feel embarrassed about saying, no, I need this time off, or, I need to change my working practice, or I'm going on mat leave and you need to sort something out about that. I think we find that a challenge.
I 100% agree with that. That sums it up very nicely. Well, we're going to now talk about what happens if you can't get pregnant or you're really struggling with pregnancy. So on our questionnaire that we got through, we had a few people say things about that. So I'm just going to lay the scene and then we'll go into a bit more detail. So we had one person reply, I tried 3 years to conceive naturally as a junior trainee. My husband and I had all the investigations, including diagnostic laparotomy and some ovarian cysts ablated. After 3 years and medical treatment to make my periods regular, we were offered IVF but decided to decline and embrace our lives without children. Almost 4 years later, we naturally got pregnant, which was a shock, but happy news. We had somebody else say, I told the rota coordinator I would be having time off for IVF and got lectured on the Christian ethics of how IVF was wrong. Another person wrote, a SBR colleague was very vocal in a busy room of work colleagues about they didn't approve about IVF, knowing that I would likely need to have it in the future. Obviously, IVF is not the only thing that a trainee might or a consultant might need for infertility, but it's just some of the comments that we got from our questionnaire. So as this is your speciality, Annabel, I'll let you take the lead.
I think it's important to say it's a real shame if people are being told by their colleagues that IVF is something that they don't approve of. It is massively increasing in the proportion of pregnancies as people are naturally leaving pregnancies later. Mostly that's career and socially related, I suppose. It's very common amongst medical professionals to need a bit of help and support sometimes, and I genuinely don't think anyone should be judged for that. If you are struggling to conceive, particularly if you are over the age of 35, or if you think there's a problem already, for example, and I suspect this is the case with the first lady you spoke about, if you're not having a regular cycle or you've got a medical problem that might mean that you feel that you're more likely to find it difficult to conceive, then you should ideally be speaking to your GP from about 18 months in of trying to start the ball rolling. It's not a quick process to get through fertility treatments, and the earlier you do it, the better your outcome is likely to be. So an IVF cycle usually runs over about 4 to 6 weeks, depending on what cycle you're having, and you have to take hormone injections. Some people find those absolutely fine, don't really have any side effects, but you can get quite emotional, you can have mood swings, you can have sort of depression and anxiety related to those as side effects. You probably in that 4 to 6 weeks will expect to need to be in the unit for about 5 or 6 appointments, a couple of which will be sort of procedural appointments and most of the others will be short, quick scans. And so you need to negotiate that a little bit with work. And what I would say, and I always recommend this to all of my patients going through IVF, no matter what their job is, find someone at work you can tell. Don't try and do it without telling anybody, because the stress of having to hide it or trying to change things last minute without having someone supportive on the work side is just a stress you don't need at that stage. And I appreciate that's not going to be feasible for everybody. It depends entirely on the department you work in, but if it is at all possible, really try to do that.
That's good advice, I think, because you can feel a bit lonely when you're first pregnant. Even if it's going very, very well, you sometimes have only told your partner and only 2 people and maybe your GP know about it. Actually, it's quite a relief when you do tell it to a friend, to even someone not at work, just somebody who can support you. I think particularly if you're going through a difficult time and not knowing if you're going to conceive, that's even more important to have them back up in a sense.
And I would say, as somebody who's been through IVF a few times, that it doesn't always go to plan. So you get given a lovely schedule where they say you'll probably get a scan on this day or this day, you'll probably take drugs this day. But actually, in none of my cycles has that actually followed. I have not followed the plan. And so it's quite stressful when, you think you're going to have a procedure this day. So you've booked your annual leave and you've taken the time off then. And then actually it doesn't happen for 4 or 5 days later because it's taken that long for you to become ready to do the procedure. And I haven't always told people for every cycle, but I've got maybe taken off more annual leave each cycle so that it covers like more days pre and post procedures, because I know that that's going to be the case. Or I've changed my place where I do IVF so it's closer to work, so I'm more likely to get the 7:30 slot to get a scan rather than having to run out of work to get the 2 o'clock slot, and in that those sorts of things. So there's little things that you can do, but it's never as predictable as you hope it will be. That's my personal experience from doing IVF anyway. And of course, there's not just over IVF, is there? So what other things might people have to do for their infertility, Annabel?
The other main treatment options are ovulation induction for women who don't have a regular cycle with polycystic ovarian syndrome. That's a little bit easier because you just take some tablets and usually have a tracking scan, probably a little bit less stressful than having to do all the injections. And then there's intrauterine insemination, which is quite a common one for same-sex couples. If you need to use donor sperm, that might be something that is recommended to you.
And in terms of doing any of these as a surgeon, obviously I personally think you need to take some leave, like, even if it's just annual leave to cover, but you would be eligible to sign off for sick leave if you wanted, or get your GP to sign you off for that. Are there any other changes that you would say for their work schedule as a surgeon that you would advise?
I think it's really individual, because there are some people who, for the sake of their sort of stress levels in terms of being able to book appointments at different times, need to take a bit of leave. Equally, if you have a fairly flexible workplace and you're someone who finds the process or would prefer during the process to feel a little bit more distracted, you don't have to take leave. Most of the appointments at the unit are relatively short, apart from the egg collection if you're having IVF, in which case you definitely need a couple of days off work. But for some people, it may be better to keep going with life as normal and not sit at home and think about things. And I think that's got to be a really individual decision to make.
So then we're going to move on to what happens if you have a difficult pregnancy. So obviously that might mean that you've had a difficult pregnancy because of medical reasons. You've got something like hyperemesis and you're vomiting lots, or you might have a miscarriage, or you might end up having to have a termination either for medical reasons or for other reasons. As a surgical trainee, just because we're a profession doesn't mean that we don't have the same stuff that all other human beings go through. And so we want to try and say if there's any things that we can suggest. We haven't all experienced them all for sure, so that we can see we can help. So some of the things that we got written back in our questionnaire was, I had a good story. I had a miscarriage while working between my two surviving children. It was the right choice for me to carry on working apart from the day of my surgical management. I was able to be open with select colleagues who supported me. I was lucky to feel that that was my choice though. And I know other colleagues will have different experiences. And somebody else wrote, I needed a termination for medical reasons. I told one consultant almost by accident when upset at work. They were fantastic and dealt with the rota, sick leave and management. They also checked in on me afterwards. They made that awful time period in my life bearable, which actually was really nice to read that we had those two things sent back. And also thank you for those people being honest in those very difficult situations. So, Annabel, I mean, you run a recurrent miscarriage clinic. Is there anything that you can offer?
I think that highlights really well the importance of telling people and how that might be something you really worry about. But in general, if you tell people, we're all humans and we want to help and support our colleagues wherever that's possible. Miscarriages are horribly common, so they happen in about 25 to 30% of pregnancies, depending on your age. They're often age-related. Most of them are just rubbish luck, as in absolutely nothing that you can do about them. They're nothing to do with you or your body or anything like that. Because they're common, lots of us will go through them. The really important thing is to recognise, I think, how difficult it is to go through a pregnancy loss, even if you're feeling quite well. And I appreciate one of those comments said that they felt it was the right thing to go through work, but if you feel that you need to take time off, please take time off.
Are people entitled to some bereavement time? Is that something that is allowed or possible other than sick leave?
Yeah, so under 24 weeks, you aren't entitled to bereavement time at the moment. But I know the government is looking into lots of different changes around support with pregnancy losses and babies on the neonatal unit and things like that. You are entitled to sick leave, though, and that can be fairly lengthy if you need it to be. And some people will need several weeks off work.
So it's okay, isn't it, to go and ask for that time off and to realise that actually this is a very brief period of your working life. And if you need time to grieve, then you need that time and it's okay to take it.
And that's something I really agree with Victoria. I think as a more junior trainee, I would have been, I wouldn't have taken sick leave for anything, because you just feel that pressure. You have to be there. You have to be there for your career. You have to be there for your bosses and things like that. And actually, I think as you get more worldly wise, as you get older, as you have traumatic things with or without pregnancy in your life, parents passing away, things like that, other things, you get a bit more protective of yourself. And actually, you might be surprised about how your consultant colleagues or other people in the department, nobody knows what their life story is. And so actually, they might be more supportive of sick leave than you think, but also it doesn't really matter if your training is extended by 6 months because you had to take sick leave at this time. It's 6 months in your life. And even with the competency-based stuff now, you might not even have your training extended. If you need to look after yourself, then you look after yourself now, and then it will get better. You will be better. You'll be able to give more to your family, your society, your work later on. I would have really struggled with that as the more junior I was. Now I would be more supportive.
I think that's valid for maternity leave as well. We are so worried about taking time out because, yes, it's quite difficult to watch other colleagues, people who haven't had children or men, carry on and sort of finish long before you do, because you've taken off a year for one child and 9 months for another child, and then you've gone part-time for a period. But actually, that's fine. And in the grand scheme of things, it's only a few years, and that's okay. And if it's the right thing for you, then that's what you should be doing.
And I guess with termination for medical or non-medical reasons, that it's similar. It's sick leave. Is that right?
Yes, yeah, it would also be sick. And if you're going somewhere for a medical procedure, it may be, particularly if you're under an NHS hospital, that they will issue you the sick note directly. You won't have to go to your GP. But they usually only do up to 2 weeks, as we know, so you might need to speak to a GP afterwards.
And how about if things happen after 24 weeks?
You would then be entitled to maternity leave to sort of rest and recover and all of that. And I think that, again, is a really individual thing. Some people will want to go back quite quickly. I think that probably also depends a little bit on your specialty. So certainly in mine, if we're exposed to babies all the time, that's going to make it often much harder. And I know several midwifery colleagues who've had to take extended time periods off work because they can't face looking after women having their babies. And I think that's perfectly understandable.
It can be a bit different for us in the sense that going back to work can be a way, as someone said on the questionnaire, a way of distracting, I guess, from what's happening. And like you said earlier, it's individual, what works and what feels right for you when you're going through these things.
So hopefully, if you wish to get pregnant, you'll get pregnant. That will come with its own challenges. So I'm going to hand over to Victoria.
So essentially, there's the practicalities of organising maternity leave, which can be quite tricky. When I became pregnant the first time, it seemed that I was the first person in the NHS to have needed to require time off and forms signed. But actually, that's not the case. I think they're hopefully getting better at it. But essentially, you need to declare your pregnancy, as we said before, and you're allowed to take maternity leave from 11 weeks before the due date, so about 29 weeks. You need to ideally tell them when you're planning to go on leave. And if you have to go off sick for any reason during the 4 weeks before, at the end of your pregnancy, then it turns into maternity leave automatically. You are entitled to maternity leave when you work for the NHS. So you need to have worked for 12 months continuously, I gather, at the 29-week mark to be entitled to it. But you get 8 weeks full pay, and then you get 18 weeks half pay and either maternity allowance or statutory maternity pay, which isn't that much. It's currently about £156.66 a week, I think. And then for the last 13 weeks, your job is protected. You're allowed to be on maternity leave, but you just get those £156 a week. And for the very final 13 weeks, you get no pay at all. So obviously, financially, this is something you have to think about carefully and work out how you can do it. There are the return to work days that you can use towards the end of your maternity leave to get back into work if you want to, and those are paid as well. So there is an element of you being able to touch your toe in the water if you want to before going back to work full time. But all of this has to be planned, and so you need to have a risk assessment done either by your manager or by occupational health, whichever you feel is most appropriate. And you need to discuss with them what you think would be right for you. So do you need to be careful about, for instance, radiation in theatre, depending on your specialty, or do you have to be careful about night shifts? Can you manage an on-call now that you're pregnant and perhaps you've got some problems with your pelvis? You probably shouldn't be running around in the middle of the night on call at that point. But equally, during the day, it can be extremely busy in ENT on call, certainly. And so are you okay to do that? Is it safe for you and your baby? And so that's something you need to sit down and really, as Paula said earlier, spell out what you think is okay and what is not okay. And it can change. And I think that's the difficulty. It's a changing picture when you're pregnant, isn't it? Right at the beginning, you can feel really tired. Someone told me just recently that, she'd felt very sick and just exhausted right at the beginning and hadn't exactly expected that. Maybe that's because we don't really talk about early pregnancy much. That's the time when we tend not to share it with other people. And actually that often is quite tricky when you're feeling very nauseous and very, very tired. And so you might need quite a lot of support just then and a bit more rest time. You might be fine in the middle of your pregnancy and then you might get tired again at the end, but it changes for each person. And so you have to be able to go back and say, actually, I need a new risk assessment. Actually, I can't do this anymore. Or actually, I'm fine. I'm happy to do the on-calls.
Yeah, and that's certainly reflected in some of the feedback that we got from our questionnaire. So we asked the question, do you have a good or bad story navigating a normal, healthy pregnancy? And somebody said mixed. I had one pre-COVID, which I worked right to the end. I was supported to stop on call at 28 weeks, was kind of the figure that people band around as the time to stop in surgery. But as Victoria's already said, you actually don't have to stop ever. You can do your on-calls right to the very end if that's what you so wish, or you can stop earlier. And that they actually report they felt quite babied. People were always trying to look after me, assuming I would feel tired and not wanting to do things as I got more and more pregnant. Part of me knows this was supportive, but I found it irritating. And then I found my second pregnancy during COVID much harder to deal with. I was taken off calls at 12 weeks and worked from home at 28 weeks. This was quite hard from a training perspective. But on the other hand, I didn't get COVID and I was quite anxious about miscarriages I'd had previously. The big issue for me was feeling dreadful in the first trimester and awkward about sharing that. I remember having a near faint in theatre when I was close to her neck, but I felt I didn't want to close my pregnancy as a consultant at that point. In the end, I would have liked to have done that earlier, but I figured I'd have had to say if I miscarried, and that was a problem. Somebody else has written, I was pregnant in COVID times and found this stressful due to the lack of guidance. I had a supportive department though, and they allowed me to work from home for my pregnancy, but this resulted in an extension of my training. Then somebody else said that they had a healthy pregnancy and they were supported. Somebody else said that they had, this is quite a recurrent theme actually, that pregnancy during COVID was very difficult. 18 weeks, the trust refused to vaccinate pregnant women. I had a bad stretch of on-call with lots of potential COVID positive patients performing aerosol generating procedures. But I emailed the clinical lead and said I was uncomfortable and vulnerable and wanted to stop the on-call, and they organised that immediately. No fuss. My decision was fully supported. And 2 more to go. I fainted or felt faints, needing to sit down in theatre almost daily, dreading going through it again. Working from home from 28 weeks due to COVID was a game changer. I'm really sad that I wouldn't be able to do this again in a future pregnancy. I could eat when I wanted, drink, sit down, talk. Not sure it's feasible to ask to not operate around 7 months, but not sure what else to do to continually not feel faint. And then, yes, I was well looked after. I have never before or since eaten so many lunches or had so many breaks. The consultants would do the easier operations so I could rest and eat and then do the challenging ones. I had the best time. That's a really nice one to finish on. But maybe we could take with the COVID theme. Is there anything at the moment around COVID, Annabel, that you know about?
COVID is linked to a slightly higher pregnancy loss risk, so we definitely recommend that people access their COVID vaccinations, which you can have when you're pregnant, and that gives a little bit of antibodies over to baby as well. Other than that, it's just taking sort of sensible precautions. Most women are young, fit and healthy, and even if they get COVID during pregnancy, it's not something to worry overly about. It's just that ideally we should be trying to avoid it for people. It was a difficult time, wasn't it, during COVID? I mean, I was pregnant during COVID. As it happened, I told my trust to sod off and I was going to carry on working, but it's just not a good stress to have really around that.
No, and it's different for every speciality. ENT do a lot of aerosol generating procedures. So for our trainees, or our pregnant people, I should say, it would have been much harder because, for instance, in pediatrics, we don't have a closed circuit when we're operating in the airway. So you get COVID, the COVID comes into your face. And so I would have said that would have been a really stressful thing because actually it's part of our on-calls, it's part of our clinics. It would have been challenging. As it happened, I came back from mat leave the week that lockdown happened, so I had different stresses of no nursery, but all the specialities in surgery are different. And as we keep coming back to, I'd love to give everybody a formula to get through pregnancy and infertility and getting pregnant, but unfortunately it's different for everybody, and that's really challenging. And it also means that it gives people who are meant to help you weaponized incompetence, if you like, where you have to know your maternity leave rules, you have to know what you want, you have to dictate. And that goes with paternity leave as well. No, nobody's going to really know. You have to know and go and say, this is what I'd like. It's a bit like doing those interview questions for your training and consultant interviews. Something's gone wrong. What do you do? And, you always look after the patient first, and then you look after the other person, and then you come with a solution or solutions. And this is the same, unfortunately.
The BMA is quite helpful for that. If you need a little bit of guidance and support, I found speaking to them over the phone was good around my first pregnancy, and I really didn't understand any of the things you were supposed to do, but there are definitely resources out there.
Yeah, and now there's online. There is the BMA website, the Royal College website, the GMC, actually, also NHS employers. Once you start looking, there's quite a lot of stuff out there that tells you what to do and how to do it. And the midwives, I found, actually were really good at telling you, right, you need to go do this at work, and now I think maybe you should think about not doing nights. I found that really helpful to have my professional colleague tell me what to do.
We want to give you some information about charities that might be able to help you if you're going through difficult times, either if you get difficult results or you want to talk to somebody about counselling for baby loss or recurrent loss or termination. So there is ARC, that's www.arc-uk.org, and they help you to go through results. Miscarriage Association, so www.miscarriageassociation.org.uk for current miscarriages, counselling for baby loss or to help with that, and that can be at any stage from 0 to term babies, petalscharity.org, tommys.org, and if you have a stillbirth, so over 24 weeks, sands.org.uk, and those are definitely places that you should use to help support you going through those terrible times.
If people are struggling with fertility, then a really useful resource is fertilitynetwork.co.uk. They are fantastic at sort of signposting where to go and giving lots of information. It was interesting, the last example you were talking about where somebody was saying about alterations during surgery and could they come off operating. It's sort of unpleasant how different you feel during pregnancy, and you never expect that going into it because you just assume you'll be absolutely fine. But certainly I felt faint with a lot of operations, and I found you do have to make modifications because you can't faint in theatre. You'll really annoy your colleagues if you collapse on the floor, which I did at 8 weeks and learnt from that. But if you need to sit down on a stool, I found a really, really tall stool so I could still do laparoscopic operating. And people are quite good about sorting that out. I also said I wasn't going to do any long procedures after a particular number of weeks, so I got put onto short lists. I think you do have to ask for changes to your work environment. And you feel exhausted during pregnancy. I also used to go and fall asleep in the doctor's mess because there was a sofa there and I could lie down at certain times of the day. And I think you just have to give yourself permission to do things like that.
That's what the on-call room is for, lunchtime napping.
Yes, exactly.
Have you worked in a trust with an on-call room? But I definitely agree. I mean, I have horrendous migraines, and I've never suffered. Obviously, migraines are meant to get worse during pregnancy, I believe. Is that right, Annabel?
They do for lots of people, yes.
Yeah, but actually mine got better because I was one of those trainees that was like, I'm going to have lunch. And for the first time, I had lunch at lunchtime and not at 4:00. And actually, I found a massive improvement to my migraines. And that has revolutionized my life since having a baby, because now I'm adamant, like, I have to eat lunch. I'm not having a migraine every day because I've eaten lunch at 4:00. And actually, it's benefited my life post having a baby. And now I just have far fewer migraines than I've ever had, thanks to pregnancy and learning that about myself.
That's a very good point. Learning to look after yourself because you're pregnant is important.
Yeah.
But I do also think that some people, I was actually fine at the end of the pregnancy. Right at the beginning, I felt very sick, but I was quite okay in the middle, and I was okay to operate. I had to sit down. So I just learned how to do everything sitting down. And the one thing that's tricky is the microscope when you've got a big bump to do a grommet. But even that is possible. And so I think it's exactly that. Everyone's slightly different, and you have to adapt it to how you are feeling and tell everybody what the situation is. If you're feeling fine, that's okay. And if you're not, then you need to have a little bit of extra support. That's also okay. So don't assume that everyone knows. I think you have to tell them. Everyone's different, and you just have to tell everyone around you where you're at to get the right support, I think.
I think every pregnancy is different as well. I had a horrible one in the middle where I had terrible pelvic girdle pain and was on crutches and thought for my last one I'm just going to be in real trouble. But I was still delivering people by forceps at 37 weeks with my last one, feeling absolutely fine. So just because you've had a difficult experience in one doesn't mean you'd have that in the next.
Encouraging words.
That is interesting to know. I've learned something.
So I think we've come to the conclusion. And we just wanted to sum up a few things that might be helpful when you're going on this journey. First of all, if you are the surgeon that is pregnant, find an ally, find someone you can talk to about your pregnancy early if you feel like you can. Also, make sure that you arrange a risk assessment with occupational health, work out your shifts, what you can do, what you can't do. And remember that it changes during pregnancy. If you need to be reassessed and need to change the plan, that's fine. You do have to be organised about getting in your MAP B1 form, declaring your maternity leave, all the rest of it. It's on you. But if you do it at the beginning, then you don't have to worry about it when you're getting to the period of birth and new babies, when you have other things to think about. Make sure you talk to your rota coordinator, explain your needs. You could think about if you're not able to operate or you're not feeling that you can be physically working, you might want to take some study leave at the end and do a few courses. I read about that. That's quite a good opportunity to use up that time usefully. And then make sure that you're really explicit if you don't want the information about your pregnancy to be shared. So if you have to tell somebody, you need to come off nights, I'm pregnant, make sure you say, but I don't want to tell anybody else yet at the same time, because that can be a very difficult information about you is shared and you're not ready for it. So those are the things that we would advise as a pregnant surgeon.
Yeah, and then basically we're going to suggest some things if you're working with somebody who's pregnant or you think might be pregnant. So first of all, if you think somebody might be pregnant, you can't legally ask them, are you pregnant? But what you can do is what we should do for all of our colleagues if you're worried about them, and just ask them, how are you feeling? Is there anything going on at home? Do you need any more support? And that just gives them an opening for them to talk and tell you if they want. The second thing is sit and listen if they tell you. Don't assume that you know what they're going through. Don't assume that it's going to be hard and tough, as we heard one of our replies to the questionnaire say, but also don't assume you know the answer to their story or that you know where their story is going. Just sit and listen. And if it is a grief situation, allow them to sit in their grief. Don't give them your story. Don't put on them what you think they should do, because you're just trying to fix a situation. They need to grieve. And whatever you do, do not use the words at least at the beginning of any sentence. At least you've already got one child. At least the miscarriage was early. At least you know you can get pregnant. Those two words, just never utter them. Offer your colleagues breaks in surgery. Ask if they want to de-scrub for a breather. Allow them to eat regularly and sit down. So maybe at the beginning of the list, sit and chat and work out what you're going to do. Maybe you could do that really annoying tonsil that they don't need for their logbook, so they can go and eat lunch at that point while they do something else. And if one of your trainees or colleagues is pregnant and you're in a position to be able to do this, so you're in a sort of leadership type position, take time to help them plan when they might go off, when they might come back from maternity leave, what their job will be when they come back to them. Just help take some of that stress off them to be able to plan. And above all, be kind.
All that remains to say here is a few thank yous. Firstly, to my co-host, Miss Paula Coyle, for her insights, and also to Miss Annabel Kemp for her expert advice on fertility. And we'd like to thank Wentz UK and ENT UK for their support with this podcast and the whole series. And finally, a very special thank you to Heather Pownall our podcast producer, for making these podcasts happen. Thank you for guiding us through this process so patiently, and for your support and your kindness talking through these delicate topics. And thank you for all the extra time and effort you've poured into this project. We're very aware of that and we really appreciate it.
This has been an incredible discussion, and we hope you enjoyed this episode as much as we have. Thank you again for our guests for their time and for participating in what can be at times quite challenging and sensitive topics. This has been our last episode in our current series. You can listen to all our episodes for the podcast provider of your choice. We also invite you to leave a review, and if you have any questions or topic suggestions, you can drop us a line at went@ent.org. Thank you for listening.